Good afternoon and good evening to all of you. Thank you for joining us in this webinar on the role of palliative care in COVID-19 infection. It gives me great pleasure to welcome all of you, and I'm delighted that I've been joined by 4 of my esteemed colleagues who are going to share their experience and knowledge of managing palliative care in this COVID pandemic. We have 2 of our speakers from the UK and also joined by 2 of our speakers from the Association of Physicians of India, and who will be also talking about the role of palliative care, but asking us and identifying specific areas of challenge and controversy. So warmly look forward to hearing them. I would first like to say a thank you to all our consortium partners, for the South Asian Health Foundation for setting up these webinars, and also for all the consortium partners, which today includes the Royal College of Physicians, the Association of Physicians of India, King's Health Partners, and everybody else, and including the Academic Health Science Network, for allowing us to do this presentation. The format will be that each of the speakers will give an overview of topics in their particular area, and the topics that we've identified are these: looking at the pharmacological management in palliative care, identifying the needs and COVID end-of-life care decisions and recognizing the dying patients, how to manage breathlessness, and also the non-respiratory aspects of palliative care, such as agitation and delirium, but also the role of hydration, infusions, and what happens with the loss of the oral route. The social and psychosocial and spiritual support is also very important. This will then be followed by a question and answer session. If I may ask all of you to be able to record any questions that you may have in the chat function on the Zoom, and we have a team who will be monitoring this, and we'll be trying to answer some of the questions as we go along, but some of them we'll be putting to our panelists as well. Just some general rules for all of us to be aware of. There will be no patient-specific questions. Unfortunately, we cannot do that, nor any patient identifiable data on the chat function, please. There will be certificates that will be handed out and mailed to all of you at the end of the webinar. And also, just to let you know that we are planning our next webinar, which will be in the week commencing the 7th of June, which will be on vaccination. So please do look out for that. So it gives me great pleasure to introduce our first speaker, who is Dr. Rajasekara. He is a senior consultant physician and the chairman of the RR Charitable Trust in Tamil Nadu, and he's going to set the context of palliative care for managing in the current pandemic, the resources required, and it's important. Thank you.
Thank you, Dr. Anupam Chauhan, and my dear panelists. Today, we are going to highlight the basics of COVID palliative care. Just a few slides only, and we'll go one by one. And all of us will go together and then do the best possible presentation. So, what is the definition of palliative care? The palliative care in COVID-19 is a multifaceted, integrated approach to improve the quality of life of the patient and their families, rather, facing the problem associated with the life-threatening COVID-19. So that is the importance of palliative care. Next slide. So palliative treatment focuses on the prevention and relief of suffering by means of rather early identification, assessment, and treatment of physical, psychosocial, and spiritual stresses. That is vital. The palliative care includes, but not limited to, the end of life care. That is very important. And the patient care should be integrated with the curative treatment rather. Next slide. So the basic palliative care includes, number 1, the relief of dyspnea and other symptoms. The palliative care intervention should be made accessible at each institution that promotes care for persons with COVID-19. And especially in hospitals, palliative care does not require a separate ward or department. So palliative care can be provided in any setting, in fact, at their home, and even in many hotels are converted as palliative care centers. Next slide, please. So to consider opioids and the pharmacological and non-pharmacological intervention, which they are going to highlight now, for relief of dyspnea that is refractory to the treatment of underlying cause and or as part of end of life care. That is again important. So the narrow therapeutic margin of opioids in the management of dyspnea requires that opioids are prescribed in accordance with evidence-based treatment rather. The protocols and the patients are closely monitored to prevent negative unintended effects due to inappropriate use of opioids. That is important. Next slide. So the palliative therapy thus includes, it also managing pain and symptoms, that is number one. Then ensuring comfort in dying, then supporting patients and families to understand and decide treatment. That we must convalesce the patients, that is coordinate the families, that is important. Then interaction, we must interact with the patients, families, colleagues, and community. Then the spiritual care, team support, and guidance of self-support. That is the founder pillar of palliative care. Thank you. Thank you. Over to Dr. Professor Anupam Prakash.
Thank you very much for that, Dr. Rajasekara. You have set the context very nicely for us. It gives me great pleasure now to introduce our colleague, Professor Anupam Prakash. As you can see, he's a professor of medicine at the Lady Hardinge Medical College in Delhi. And Anupam is going to talk about the non-respiratory aspects of palliative care, the environment, the psychosocial support, and the pharmacology. Thank you very much, Anupam.
Good evening, everybody, and thank you, Dr. Chauhan. So I will continue with the COVID palliative care, and I think it is of utmost importance that not only pharmacotherapy, but there are so many things which actually to be taken care of when we actually talk of palliative care. So I will start with delirium and agitation. Important to understand, I think we have gone to the slide ahead. We need to go one slide back. But anyhow, the important thing is that we need to cater to one of the important things that patients have. These patients are actually isolated in hospital, and there is a degree of agitation which could be part of anxiety or delirium. So we have two things which are there. One is agitation, one is delirium. Now agitation, when we talk of agitation, agitation just means an increased psychomotor activity, and it could be because of so many restraints which are there, because the patient is alone, patient is anxious because of the surroundings, could be because of some pharmacological agents also. There are a whole lot of antibiotics which are being administered, and at times because of the illness or because of the drugs, the patient may also have delirium. So delirium per se is like agitation could be a manifestation of delirium, but delirium is actually a depression or a altered sensorium which is there. So when we have a consciousness altered, that is the earliest stage of delirium. So agitation and delirium, we need to understand why actually the patient is agitated, or is it a manifestation of anxiety or delirium. In that case, obviously, we will need to put the patient, change his or her surroundings, put the patient in a quiet room, put a window side bed, because that will actually take the attention of the patients inside the ICU, and take the patient will be exposed to situation outside also. Avoid physical distance, because physical distance per se could also be the reason for agitation. Then the pharmacotherapy, when we use for mild patients who are just agitated, we can use oral haloperidol. We are usually using this as medicine personnel. We commonly use this drug, and in COVID also we are using oral haloperidol, which can be given as 0.5 milligram twice a day, or it can be up titrated to 10 to 15 milligram per day. Those patients who don't respond or require injectable therapy, these patients actually give injection haloperidol as basis. If the patient is continuously agitated or delirious, then we need to give it on a 6 to 8 hourly basis as 2.5 IV 6 to 8 hourly. Yes, at times the patient may still not be controlled, or haloperidol may, the first dose may take some time to act. In those patients, we can give a small dose of midazolam. Now there is a word of caution, because most of these patients will be elderly. Especially delirious and agitated people are elderly. In those patients, we should use a slightly lower dose of midazolam. Maybe at times 1 milligram, even 0.5 milligram may be sufficient. You can always repeat it if the patient is not controlled, because as a slow IV injection acts virtually immediately, although haloperidol takes a little time. And if the patient is in ICU setting, definitely use phenobarbital or propofol. So these are agents which can be used for delirium and agitation. Next. So the next is pain. So when we talk of pain, it is important that we understand that pain could be because of many things. It could be thrombophlebitis, it could be neuropathic pain. So the mildest agent, especially those patients who are hospitalized, they should be given oral paracetamol or crocin or whatever is available. And if the patient is not taking orally, you give the patient an IM preparation. We also have an IV preparation which is there, so we can use this which is simple. Avoid NSAIDs, because hospitalized patients, already I said, antibiotics, they may be having heart dehydration, all those things. Neuropathic pain, we need to give gabapentin, although it is not so common, but yes, you need to give. But those patients who are still not controlled, you need to give morphine. Fentanyl we are not using so often, until the patient is in ICU, but morphine SOS is being used. We can have other symptoms like vomiting, secretions, more of respiratory secretions, so you can use metoclopramide or glycopyrrolate, which is being used in our setup very commonly. Apart from this, because there is a element of anorexia, patients have a very metallic or a loss of taste, and glossitis, oral ulcers. So these patients require hydration support. Those patients who are continuously on BiPAP, they actually at times require also non-invasive ventilation. They also require at times total parenteral nutrition support. So these are things which are required. So hydration, electrolytes, these are important things which we need to take care of. Next slide. Apart from these symptoms, it is important that we give the patient adequate psychosocial support, which is very, very important. It may be at the level of patient, doctor-patient relationship. It may be at the level of a doctor to family relationship also. As Dr. Rajshekhar rightly said, it is very important to cover both these things. It is a difficult proposition. You are in PP, the doctor is in PP, and the patients need to be addressed. Patients don't recognize you at times. It is very difficult. All doctors, nurses, paramedics, they all appear same to the patient. Patient is not so much oriented to read your names also, even if they are written. But yes, we need to reduce panic. The patient is far away from relations. Relations come to meet the patient because of fear of COVID. And the patients have the fear of future, because the future is uncertain. There may be patients dying on the ward itself. So patients don't know whether they will actually walk back home or not. And obviously, I said barriers. There are barriers like PP, communication, difficult to recognize, and the patient could be delirious, patient doesn't recognize. And the other barrier is a long time to recovery. Some patients who are on non-invasive ventilation or a high flow nasal oxygen, they may take a long time to recover also. So we need very compassionate with the patient and ensure that the dignity of the patient is maintained. When we talk to the family members, again, where do we talk, when do we talk, how do we talk is very, very important. The family members in COVID, it is a pandemic of enormous proportion, and they are all in a state of denial. We need to see when actually we need to talk to them. So you need to talk to them outside with all due precautions, because they can also be COVID positive, symptomatic carriers. You need to have a desegregated room to talk to them, because it's not easy to talk openly to everybody and in front of everybody. Every patient and every condition, patient's condition will be separate, and how you talk is again very important, because that is how actually it will manifest. And you have to, I will come to it in the next slide. Can I have next slide? So when we talk to the patient, you have short of the patient, check the emotions of the family members as well as the patient whenever you give them support, because the patient may be agitated, the relatives may be agitated, the relatives may be very angry, they may be anxious. So all these emotions have to be checked, and then you have to address them individually. You have to reassure not only the family but patient also, and these have to go simultaneously and differently. In our setup, we allow patients mobiles also, and we encourage them to make WhatsApp call or other calls, so that patients can talk to them, the relatives at home can see, and they are at some they understand that yes, patients are being taken care of adequately and they are improving. So you need to you have to assess what information you want to transfer, and you need to elicit the consent also. The information has to be delivered empathetically, that is very important. And as I have written, acknowledge and validate emotions. So you have to understand what is the degree of emotions, acknowledge them, address them. And if the patients are angry, address that also, because it is very, very important. Can I have the next slide, please? I think this is one of the last slides. So important is recognize the distress that the patient is in, the family members are in, recognize the grief. Any loss, whether admission, whether anything, it is a loss to the family, because the member is not there, all things. And this loss leads to distress, this leads to grief. So you have to of all these things, but importantly, rule out a psychiatric morbidity, because if there is any psychiatric morbidity, you need to address that also. So you need to ask the patient to vent out, ensure catharsis is there. If there is psychiatric morbidity or difficult grief, then you need to take a opinion of a psychiatrist also. Next slide. So it is important, give honest information in simple and accurate terms. Avoid false reassurances, because it is important. If you give false reassurances, patients would be agitated, angry, relatives would be fighting with you, and then there are a lot of legal issues also. Importantly, the doctor has to maintain a calm behavior always. Reassure, I already said, catharsis, it helps normalize anger as well as grief. Let the relatives vent out their anger, vent out their problems. And this is very important, that you promote realistic hope and goal setting. I tell the patient that yes, you were on 2 liters yesterday, now you are on 1 liter. You were on HFNO device today. So that is realistic goal. You encourage the patient, because in this setup, a positive thought process is very, very important. We are having studies on yoga and meditation in patients who are admitted, and those obviously not severe patients, but mild to moderate patients. We are allowing them to have relaxation techniques. We have Yoga Institute in collaboration, and we are trying to maintain that those studies also. So relaxation techniques are there, yoga and meditation. These have a very important role. And yes, obviously, as I already said, if the patient has a psychiatric morbidity, then always treat the patient. So I think that covers most of the things. If there are any things which are left, we would add them in the panel. Well, thank you.
Thank you very much indeed, Dr. Prakash, for a wonderful review of all the major topics in managing the non-respiratory aspects of palliative care. So thank you for that. Our next speaker, Dr. Sabrina Bajwa, has been delayed. So unfortunately, she'll be joining us a little later. So what I would like to do is welcome my colleague, Dr. Ian Lowry, who was talk number 4, to come up next. Ian is a Macmillan consultant in palliative care and an honorary clinical senior lecturer in palliative medicine in Manchester as well. And Ian is going to be describing the UK experience following the management review of nearly 1,000 patients in Manchester. So Ian, thank you very much.
Thanks, Anup, for that. Good afternoon, good evening, everyone. I just want to say thank you for allowing us to talk on this webinar this afternoon, and to send our good wishes and our thoughts and our prayers to all our colleagues and friends in India at this difficult time. I want to describe our regional audit during the first wave of the COVID-19 pandemic. I work in a hospital with a regional infectious diseases unit, so we saw patients quite early in the year last year. And this regional audit covered almost 1,000 patients, as you see, relatively balanced in terms of male and female patients. The mean age was elderly at that time, and I know that that has changed over the last year, but if you look at the range from 37 years old to 105 years old, there is quite a difference, isn't there? Specialist palliative care was involved in the care of these patients, usually in the last 5 days, but mostly in the 24 hours prior to these patients dying. Our highest peak of deaths was in April 2020, but obviously that had built up from March and then decreased, thankfully, after April. And in England and other parts of the UK, we use an individualised plan of care, which is tailored towards an individual patient's needs when they're in the last few days of life, in order to provide them with truly individualised care based on their individual needs. So that was used in 61% of cases. These 927 patients were where COVID-19 was mentioned in either the first or second line of their death certificate. The one thing we did see, and this might explain specialist palliative care being involved in the last 24 hours of life mostly, was the rapid deterioration of these patients. Unlike any other pneumonia or pneumonitis that we've come across, quite often, especially in patients with multiple comorbidities, that we were seeing people coming in to hospital and deteriorating and dying within 12 to 24 hours of admission. The main problem that we did see was breathlessness, and it wasn't unusual to see respiratory rates in the high 40s with patients, and obviously that is incredibly distressing for patients. So looking at the drugs, so next slide please. The prescribing we were using. So opioids were prescribed in the majority of patients, 83%, and used in 2/3 of those patients. We tend to use opioids, as I'm sure you will do, in chronic lung disease where breathlessness is a feature. And it did seem to be effective in a lot of patients. I'll mention syringe drivers at the end of the slide. Midazolam, prescribed in 82% of patients, and again used in 58%. And from my own practice, I found that actually for breathlessness with someone with a respiratory rate in the 30s or 40s, midazolam was actually more useful. This was in patients who we expected to die. Sadly, and the goal of care, the ultimate goal of care, was reducing their distress. So actually midazolam was really, really useful. Haloperidol was prescribed in 11% of patients and used in 26% of them. Levomepromazine, I'm not familiar with the availability of levomepromazine, the broad-spectrum antiemetic in India, but we use it second line for agitation and delirium, prescribed in just over half of patients, used in about 10%. And then anti-secretory medications such as glycopyrronium or hyoscine hydrobromide were prescribed in just over 3/4 of patients and used in about 1/3. In terms of syringe drivers, one of the big concerns in the UK at the start of the pandemic was that there wouldn't be enough syringe drivers available to provide 24-hour infusions of medications. Sadly, the stark reality of the pandemic was that we didn't actually use syringe drivers in a lot of our patients because they were deteriorating too quickly for them to be of benefit. But they were used in terms of opioids and midazolam in about 1/4 of patients. Practice differs across the world in terms of how we deliver medications at the end of life. In Great Britain, United Kingdom, injections are generally given subcut because they're less painful, and patients tend to have an indwelling small line, a catheter, with which to administer these medications. We find that there's very little place for IVs at the end of life, and if someone isn't requiring IV access for other reasons, there's little place to put in a cannula just for opioids or midazolam, etc. Because intramuscular injections hurt, so subcut's the way to go, as I say. Next slide, please. Something really interesting that came out of the audit, which was also upsetting, was that only 41% of patients had someone with them when they died. Obviously, there was significant visiting restrictions in the UK, which varied from place to place. Some trusts, hospital trusts, would not allow any visitors at all, even for patients at the end of their life. Some trusts, my own included, would only allow one person for 1 hour once a day at the end of life. This was to reduce risk of passing on COVID to other patients or to staff on the wards. But in only 16% of cases was the person sitting with the patient at the end of life a friend or a relative, which shows you the significant psychological impact that this may have going forward for many years to come. And when somebody was with the patient, they were much more likely to be prescribed what we call anticipatory medications. So that's your morphine, midazolam, anti-secretory and antiemetic, and they were more likely to receive the medications for pain or agitation. So this was an interesting finding, in that staff were so busy caring for patients that they often relied on someone with the patient to be able to inform them of symptoms and signs of agitation or delirium. Next slide, please. What does this tell us? Actually, patients only require low doses of medication at the end of life when they're suffering from COVID-19. That's obviously a very broad statement, and there were the odd exception where patients needed higher doses of, for example, midazolam or levopromazine to manage their agitation. But actually, medication was used less than we may have expected before or at the start of the pandemic. As I've mentioned, syringe drivers were used in less than a quarter of cases, so that fear about lack of availability of syringe pumps didn't turn out to be the case. Having someone sitting with a patient, that needs more exploration, so it resulted in more use of medications, and hopefully resulted, although the audit can't definitively say this, in a patient being more settled when they died. And we also found that involving palliative care services, specialist nurses, doctors, physicians, etc., increased symptom control interventions. And again, the audit can't clearly definitively say this, but the trend does seem to be involving palliative care resulted in better control of symptoms at the end of life. I think the other thing we've got to appreciate, obviously, previous speakers have mentioned psychological impact, etc. But we have to recognise the psychological impact on staff as well as patients. And I don't know what the staff in India are feeling at the moment, but I can only imagine, based on my own experience, that they're suffering a lot of distress themselves. Distress because of the cases they're seeing and the way people are dying, distress for having to limit visiting into hospitals, distress because they're tired. It's really hard work, and our hearts go out to all of our colleagues in India. Next slide, please. And at the end of this, you may be like my cat, Archie, one of my two cats, who's very tired and will need a rest. And I think all healthcare workers will need some time to refresh, regroup after this. Thank you.
Great. Thank you very much, Ian, for presenting that review of over 900 cases. As you see, there's a lot of messages to take from that. whilst we are still waiting for our fourth speaker, I wonder whether we can just take some questions, if that's agreeable. There are some questions that are appearing in the chat function, but before we go to that, maybe if I can ask all three of our speakers really, is that in the UK experience, we saw many patients that were far older than usual who are unfortunately suffering as a result, and obviously most experience with palliative care occurs with age. But in the second wave, we saw far more younger patients with less comorbidities. Do you have any observations on how to deal with those groups of patients, whether their needs are slightly different, and what is their pharmacological response? So are there any age differences that we need to take account of?
I'm happy to answer that one, Anup. Yeah, second wave, younger patients, sort of in the 40 to 60 years old age group, we were finding that they were surviving longer, and many of them recovering as well. And from your own practice, you'll know that. So that's when more use of syringe drivers or regular medications were required. So we had to use things like morphine and midazolam for longer with them. I suppose the other thing, just to mention about us gradually getting younger patients, and the one thing that we noticed in the UK, definitely where I am in Manchester, was a huge drop in the usual presentations of patients that we would normally see in palliative care. So a huge drop in the number of patients with new malignancies, and therefore several months down the line we're seeing many more patients presenting with very late disease. So that's another effect of COVID in a way that the palliative care physicians and all physicians will probably have to deal with going on.
Great, thank you, Ian. I have one more question, which is really interesting. I think I'd be interested to know how our colleagues in India are going to manage this, because we've seen the rise in the number of mucormycosis cases as well, sinus infections, and obviously skin as well. And this is something that we have very little experience of in the UK. So these very significant upper respiratory symptoms in some of these individuals in the palliative care sense. Do any of our panelists have any thoughts on dealing with sinus infections and pain and distress? Anupam, you might wish to take this.
Yes, I will just confirm, sir. You are absolutely right. We had a few cases last year also, but this year the number of cases is far more. The peak is much more. We have at roughly 4 to 5 times the cases that we had last year. And in fact, we are with patients of mucormycosis inside our wards. We have right now patients in our wards out of the 70 patients that are right now admitted. Although Delhi is seeing the surge is on the decline in Delhi, but still the cases are there. Obviously, there are a number of issues in palliative care for specific patients. It is number one, we had talked about pain, yes, which is important. So pain I had just dealt, but the number two thing is that there is a lot of panic. So a lot of psychosocial support is required. The other thing is a lot of these patients require debridement. So they will end up losing and prolonging their agony. So that will require a lot of setup. There will be some requirement of skin transplantation, debridement, at times enucleation of the eyes. So there is a whole lot of damage, and the recovery is going to be very, very prolonged. In fact, even the toxicity of drugs also takes a lot of time with these patients, and they are really very disturbed. And we need to take care of the psychiatric morbidity as well as psychosocial support for the patients, because they are already down with the pandemic and the disease per se, but then they go on to suffer more because of that, and it is just unprecedented. COVID was unprecedented for them. They do not accept. They are in a state of denial, as I said, and then they go into a further down state, because suddenly they find that yes, your patient should be okay after 14-15 days, but then they go down, and mucormycosis takes weeks. It takes 4 to 6 weeks, because 3 weeks so we have to give antibiotic only. That is a long drawn course. So that is about my opinion.
Great, thank you very much, Anupam. I'd like to thank all our attendees for the questions. So please keep those questions coming, but I'm delighted to welcome Dr. Sabrina Bajwa, who has just joined us. So Sabrina is a honorary consultant in palliative care and a senior lecturer at King's College in London. And she's also the clinical the lead for the NIHR South London CRN. And Sabrina is going to talk specifically about breathlessness and pharmacotherapy. So thank you, Sabrina.
Thank you. Thank you for the introduction and thank you for the invite. So today I'm specifically going to talk about the breathlessness of COVID. Next slide. So early on in the first wave of the pandemic in London, and I work at King's College Hospital in London, which is a busy teaching hospital with a large socioeconomically deprived population. We had a tsunami of patients and we were overwhelmed with patients in April last year. During our clinical time managing these patients, I brought together an international group of palliative care and respiratory specialists to give clear guidance on the management of palliative care needs of patients with COVID-19. And this was published in April 2020 in the European Respiratory Journal. Within this guidance, you can find clear step-by-step pointers on the pathophysiology, incidence and treatment of the main symptoms of COVID. And today I'll be focusing on the breathlessness. Next slide, please. So 1 in 3 people who have COVID are asymptomatic. The more severe the disease, the more likely you are to have the main symptom of breathlessness. So the highest incidence of breathlessness is in those with severe disease and in those, and it's expected in those who are actively dying. The causes of breathlessness in these patients may include viral lung infection, interstitial pneumonia, and fungal infection with reduction in the lung diffusing capacity. When patients get acute respiratory distress syndrome, they become acutely breathless. These patients are also prone to increased clotting, so they get pulmonary embolisms, which cause breathlessness. And also, their breathlessness is contributed to by emotional, environmental, and cultural and social factors. Next slide, please. So breathlessness is complicated. The subjective feeling of breathlessness does not necessarily always correlate to oxygen saturations. You can have oxygen saturations of 100% and still feel breathless. Conversely, you can be hypoxic and not feel breathless, and that is because there is a complex interplay of not only pathophysiological and physiological factors, but also emotional and higher cognitive factors superimposed on the context which influence whether you feel breathless. Therefore, physiology, as well as pathophysiology, cognition, emotion, and context all affect how breathless you feel. Next slide, please. The potential reversible and treatable causes of breathlessness should be managed appropriately. However, in addition to these treatments, we should aim to treat the subjective feeling of breathlessness that the patient experiences. The main way that we do that is through non-pharmacological and pharmacological measures. The main non-pharmacological measures are meeting information needs and allaying anxiety, relaxation therapies, breathing control and repositioning. And the main pharmacological measures are oxygen for when the patients are hypoxic. There is no evidence for oxygen for patients who aren't hypoxic, but there is evidence for opioids and benzodiazepines. Next slide, please. So how should we manage intractable breathlessness? First and foremost, all reversible causes and any underlying pathophysiological processes should be treated. Then how you manage depends on the severity of breathlessness. If the individual is largely breathless on exertion, then the focus is on non-pharmacological measures. as the severity of the breathlessness increases, the focus on management becomes more pharmacological, with an almost complete focus on pharmacological measures at the end of life. Next slide, please. A fundamental part of managing anxiety-related breathlessness is to manage information needs. So these leaflets, which we developed as part of our guidance for the European Respiratory Journal paper, discuss the symptoms that patients might experience and the drugs and treatments that may be used to treat them. Including in these leaflets are the symptom of breathlessness and the use of opioids and benzodiazepines to manage them. These leaflets are available for both patients and families and friends, and we have had the leaflets translated into Punjabi, Urdu, Gujarati and Hindi, and they're all available on this website. Next slide, please. So the mainstay of non-pharmacological treatment is very much around having control of your breathlessness. So one of the things that we have developed at King's is some clear guidance for patients, which they're able to use at home or in hospital if needed, on how to manage the breathlessness. And this guidance includes details about how to position yourself to help reduce the breathlessness, how you can reduce abdominal and tummy breathing, slow down your breathing, and actually how breathlessness affects you on a day-to-day basis, and what you can do when you're at home to reduce your breathlessness on when you're eating and drinking, when you're anxious, and how to keep active as well during this time. This leaflet can be downloaded from the link shown. Next slide, please. So within our European Respiratory Journal article, we also talk about the pharmacological management of breathlessness. So for patients who are able to take oral medication, the mainstay would be morphine and would be the use of immediate release morphine. For patients who have distressed breathlessness at rest, then actually the intervention that's used would most likely be either the subcut or IV morphine, and the starting dose would normally be 2.5 milligrams. For these patients, as I said before, there is a complex interplay of their anxiety playing into their breathlessness, and it's important in these instances to use a benzodiazepine. And here in the UK, we would use midazolam in these instances. So what we were doing for the patients in the UK is setting up infusions, either subcut or IV, early for these patients if they were distressed by their breathlessness. And often the starting dose would be morphine 10 milligrams with midazolam 10 milligrams over 24 hours, and reduced if patients had renal failure. And it's really important when these infusions are started to make sure that you have as required or PRN medication available for these patients. And it's very important that for these patients that you do monitor for side effects, especially around nausea and vomiting. If you don't have a continuous infusion available, you can give injections every 4 hours. And I have just put a link here of where you can get conversion doses for different benzodiazepines if you don't have midazolam available in your units. Next slide, please. So I just wanted to give you an example of a case study of a patient that was admitted to King's and how we managed his breathlessness. So this is Mr. RB. He's a 64-year-old non-English speaking. He was actually Punjabi speaking, who came into our hospital. He had metastatic lung cancer. So he was admitted in January of this year, and he was admitted with a COVID pneumonia, and he was COVID positive swab in A&E. So he was on admission. We routinely were giving information leaflets, and whilst the medical team were focusing focusing on the active management of his COVID pneumonia with remdesivir and steroids, we focused on the non-pharmacological management of his breathlessness. So at that time, he also got the leaflet on positioning and the other aspects of non-pharmacological management. We also ensured that on his drug chart, he had as required medications so that the nursing staff could give it to him as needed. Over the next few days, he had a poor response to the treatment that the medical team had instigated, and he'd started to access the morphine that was written on the as required side, and he was becoming increasingly anxious. As a result, we started a 24-hourly subcutaneous syringe pump of morphine 10 milligrams and midazolam 10 milligrams, and we also ensured that he still had the PRN doses written up. Over the next 24 hours, unfortunately, he continued to deteriorate, and his oxygen saturations were only 75% on that should be on oxygen on a 15-litre rebreather, and he was agitated as well. And he'd been accessing a number of the PRN doses of the morphine. He'd had 2 doses of the morphine and 3 doses of the midazolam as he became increasingly anxious as he was desaturating. So at that point, we increased the syringe pump up to morphine 15 milligrams and increased the midazolam to 25 milligrams. And this was because he was quite clearly saying to us that the midazolam was helping him more at this point. And that often happens towards the end of life. And again, we ensured that he had, as required, medications to be used in addition to the syringe pump. And we increased the dose of the, as required, midazolam to 5 milligrams in line. At this point, we were able to get a family member to come in and visit him, and he died comfortably overnight on that night. Next slide, please. So this is just a final resource that I wanted to make you aware of. This is another piece of work that's come out of our department, but it's a BMJ practice pointer where we actually talk about the palliative care for patients with severe COVID-19, and we give a succinct way for you as clinicians to manage their palliative care needs. And the key message really is that you need proactive management of symptoms. You need to go look for the symptoms. You need to make sure the PRN or as required medication is already available for these patients to get it. That we need to make sure that we're actively managing these patients' symptoms alongside their active medical management, a bit like we did for Mr. RB, and that we very much focus on parallel planning, that we are doing everything that we can to make these patients better and to survive, but at the same time, we're reducing their distress and suffering as much as we can. And that it's really important that we communicate where possible with the patient and certainly with the family and friends to allay suffering and ensure all information needs are met. Next slide, please. And this is just a final slide of some of the COVID research that we've done as a clinical academic department here at the Cicely Saunders Institute of Palliative Care, which you might find useful as a resource. Next slide, please. Thank you.
Thanks very much indeed, Bruna. And if I could ask the panel to put their cameras on, that would be fantastic. Apologies for the slight change in order. So hopefully we're not going to have quite so long for questions now, as we had a few questions in the middle. But this is a question for Dr. Anna Pam. So hopefully you're there for us. Thank you, that's fantastic. Anna Pam, we've had a few questions in the chat about actually how is palliative care being provided to people who are dying in their homes, whether that's because they've chosen not to be admitted to hospital, or whether it's because they are unable to because of a lack of beds, because that's been highlighted, as we know, in India, but also colleagues have highlighted, colleagues from Texas have highlighted in the chat. So how are you providing palliative care to our patients who can't be admitted?
Well, that is a very valid question. Many of our patients, those who actually require hospitalization also, are being managed on oxygen concentrators at home. So that becomes a problem. And yes, obviously, home domiciliary doctor care is not available right now. So what exactly is happening is there is a whole lot of teleconsultation which is available. Nearby hospitals, all of them are providing prescriptions and they are guiding. In fact, some doctors are also teleconsulting by video calls also. And that has come as a big way forward. And in fact, the National Medical Council, the Medical Council of India, the erstwhile Council of India had actually at the beginning of the pandemic authorized teleconsultations because prior to that they were not legal. It was not allowed. So partly telemedicine has converted to teleconsultations and it has whole lot of actually changed the world. And everybody, because COVID, now there is much of stigma, nobody wants to see paramedics, nurse doctors and patients. But yes, teleconsultation has proved to be a boon and many of them are using it.
That's very helpful. So you've got the teleconsultations. How are the medications actually being given?
Yeah.
Right. Dr. Rajasthan.
Medications also are being, sure.
Jessica, I think you were answering as well. How are medications actually being given to people in the community if they can't swallow?
Prescriptions are being written and on WhatsApp to the patients, and they can get it on showing the WhatsApp. That paper they can take a copy of the printout and be seen. So those signals of the doctors are valid. So you don't have to actually visit the doctor to collect the prescription. A printout of that copy. Even the central government health scheme. This is the largest scheme of central government beneficiaries here in India. So we are just writing down the prescriptions and they get it. In fact, the system has been at such an extent that it can be actually repeated. The chronic medications, diabetics, etc. Although they can just get the prescription repeated or just re-indented, the medications can be used by the chemist without even a repeat prescription. So it has some fallacies, but yes, patients don't need to go to the doctors. They can just send the prescriptions and they will get the medications. So that is the ease that is there right now in India.
Thank you very much. And Rajessica, did you have something else to add there? I mean, I was thinking about actually how it's given. If it's, we sometimes give medications subcutaneously, how are families doing that, or are the patients just having oral medications they're being looked after in the community? Dr. Rajessica?
We train many health assistants to help in teleconsultation. It is not a big issue because we do by even our health family system of our government has approved. In fact, I am a permanent member of Zoom application. With Zoom, I do teleconsultation. It is a user-friendly application even for patients. So we ask the questions and all, and then we write down the prescription and send it by WhatsApp, and they will give a printout to the patient. And in case if the patients are not ambulant, we will courier the medicine rather. So to prevent infection. And sometimes we send people with very guaranteed, we will send it to their home. So the patients need not loiter here and there, at least to prevent the spread of infection and keep them assured of their recovery. That's important.
Thank you.
And also you have asked a question. You have asked a question I saw that is regarding the attenders. How do you ensure this anxiety and all? In fact, we assure we don't apprehend the families. That is very important. So what we suggest is as early as possible, you report to the doctor. So don't go at the end. Once the oxygen level reaches 95, we will train them how to pulse digital pulse oximetry, temperature, how all those things. We have donated so many things in many centers, even digital BP apparatus and all. So it is very easy for us to monitor them. So every time the attender, even night 1:30, we had a case, and most of the hotels and all we have converted as palliative care, so that we don't lose a single case. If they come early, we'll try to recover at the earliest possible. So all antiviral drugs have got their own limitations. Nobody knows which antiviral drug is effective. That is the problem. So if they come early and reassurance and palliative care, almost we are not proud of to say we have not lost a single case in this pandemic situation. So because they have reported to us early, that is the important thing. We have to reassure and we should not apprehend the patient. Oh, this oxygen has come to this level. Then we should not raise their eyebrows. The patients will be apprehended. That is important. And also in presence of patients, we should not talk what is the situation. We will ask the attenders and talk separately. That is very important.
Thank you very much. And thank you also, I've seen in the chat as well, apparently rickshaw pullers have been used to help distribute medications and also family members. Ian, what about your experience in Manchester delivering palliative care to people who either, well, who've chosen not to go into hospital but are still dying of COVID? What's your experience?
Well, I think we're quite lucky in Manchester because we've got quite a comprehensive community palliative care service, but also the district nursing service that we have all about the UK, although it does vary from place to place. So we have community nurses going in to patients' houses, the anticipatory drugs in the house so that they can give injections, which happens in a lot of places. I would imagine just because of the size and geography of India, that sort of system isn't kind of readily available, maybe in larger conurbations. But we've not had many problems in providing at-home hands-on care. Sometimes difficult to get a doctor to see the patient, but then we're all doing, our colleagues are in India, things like WhatsApp and video consultations, etc.
Thank you very much indeed. And Sabrina, thank you for your overview of breathlessness. One of the questions we've also had on the chat is actually about the psychological effect, managing something like breathlessness is a challenge. What's the impact that you've noticed on your colleagues and the nurses? I know it's been very relevant, I know, in India as well. What psychological problems have you noticed?
I think that the psychological impact has been large. I think initially it was around the fear of the unknown. So in wave one, it was not knowing how bad the disease would get. And I think I personally and a lot of my colleagues were really surprised at how quickly some patients deteriorated, and that was a real shock to the system to see patients deteriorate so rapidly. You may have seen them at lunchtime, and then and they were talking to you at lunchtime, and an hour later they could be dead. And I think it's really it made us really recalibrate and really think the palliative care that we were delivering, and realize that we didn't have the time to sit back and do that very holistic assessment that we've been used to doing before, say with cancer patients, and we've almost been spoilt for time, but we were having to then readjust and start doing consultations which were very rapid and really focusing on the main things, and going in and delivering interventions, not ones which from a pharmacological point of view we might start at a very low dose and then think about in the next day or two titrating the medications up. What the focus had to be is at this point in the next 20 minutes, half an hour, we need to get this patient's symptoms under control, because tomorrow they won't be alive, might not be alive. And so it was a complete change in the sphere of how we our palliative care practice, and I think that has probably changed all of us forever.
Thank you for that. I'm about to hand back to Anoop, but I think that message about it's changed you forever is the same for many of us in the UK, but also for our colleagues in India who are describing, you know, Anupam discussing, you know, WhatsApp messages, digital consultations, you know, using rickshaw drivers and families. And I'm sure it's changed for all of us, and there will be lots of learning to go forward. So thank you very much for answering the questions. I've got lots more, but I'm afraid we haven't got time. So I'm now back to pass back to Anoop and say thank you to everybody.
Great. Thank you, Alison. Well, and on that note, I'd like to say a big thank you to all our partners for sponsoring this series of webinars, but also in particular our speakers for giving up their time today, and also all of you as our attendees. This is a very distressing time for every healthcare professional, their families and their carers as well. And we hope that the information contained in this webinar will have given you some insights that will help you in your clinical practice as well. So thank you. So just to let you know, the certificates will be sent to you, and the next webinar is on vaccines, and that will be commencing on the week beginning the 7th of June. And I would also like to take this opportunity to thank our backroom staff who have been integral in making sure that this webinar has been successfully delivered. That includes Raj Gill, Bernard Allen, and Alison as well. So a huge thank you to you. And also thank you to Harpreet Sood and Amit Saraf from the API, and my colleagues from the RCP in helping convene this webinar. So on that note, I'd like to thank everyone, and we look forward to seeing you for the next webinar. And just as a reminder, this recorded webinar will be available on the AHSN website. So thank you again.
Thank you. Thank you, Dr. Anupam.